Hello everyone, welcome to another episode of next Saviours Essential Question Series NEET PG 2025. Today we are going to have a discussion on the complex question asked from the topic that is dehydration in pediatrics. Whenever we see a question related to dehydration and when we see the features like child is lethargic, sunken eyes, dry mucous membrane, prolonged capillary refill, and a very slow skin pinch test, then immediately we are in a habit of categorizing the patient into no dehydration, some dehydration, or severe dehydration. And then we try to neglect the important information which is provided in the question, that is low blood pressure, the high heart rate, serum sodium levels, and serum osmolality, and then we struggle in between the options. So, when you look at the question related to dehydration, not only the features of categorizing the dehydration into no, some, or severe dehydration is important, other features like if serum sodium levels are given are equally important for you to reach the correct answer related to that particular question as far as management is concerned. So today we'll be categorizing our discussion into the contents of that how to decipher these questions. One is to identify the cause of dehydration. Extremely important. Like whether the blood in stools present or not. If the blood in stools are present, is it associated with fever or not? The foul smelling stools are present or not? The watery diarrhea is present or not? If there is no diarrhea at all, the patient is only having vomiting, that is responsible for dehydration. So all these things will be leading to a different set of management. So cause of dehydration is the first thing that you have to identify in these kind of the questions. Second is the importance of the sodium. You know, because the dehydration is managed by fluid resuscitation or the replacement of the fluid, and sodium is the important component of the fluid. So sodium levels are very important in identifying or deciding the management, that when to use the isotonic fluid, when to use the hypotonic fluid. Does all the patients having hypernatremia requires hypotonic fluid or not, or all the patients of hyponatremia requires hypertonic fluid or not? Identifying the concentration of the sodium in the question is extremely important for you to reach the correct answer. Then comes the role of type of dehydration, whether the patient is suffering from some dehydration, severe dehydration, or no dehydration at all. And after that, you will be coming on to the replacement therapy or the management of that particular patient. So these are the three factors which are needed, at least needed to be recognized in the question. So let's start with the first one, that is identifying the cause of dehydration. As I told you, that most of the time, in case of acute gastroenteritis, is the commonest cause, which could be viral majority of the times, and is responsible for equivalent loss of sodium and water. That means it causes isotonic dehydration. Similarly, if there is only vomiting without any diarrhea, then there is more loss of the chloride and it results in hypotonic kind of the dehydration. Diabetes insipidus, because of complete water loss, it will result in hypertonic dehydration. Burns in the late stages causes hypotonic dehydration. Bloody diarrhea with or without fever might influence the outcome, because in some of the cases antibiotics might be required, but if there is no fever, then antibiotics have to be avoided. So identifying the cause of dehydration is extremely important. And when we will be talking about the antibiotics in the management, then there will be a categorization of how these causes are responsible for changing the management of the question. Next is identification of the serum sodium level. The second thing which you have to look for is the serum sodium. As we have already talked about, that sodium is an important component of the fluid replacement therapy. So isotonic dehydration is 130 to 150, which is normal. But if there is hypertonic dehydration, the concentration will be exceeding 150 milliequivalent per liter. In case of hypotonic dehydration, the serum sodium levels will be less than 130 milliequivalent per liter. And these are the various causes for this. But majority of the times, if at all the examiner wants you to mark the answer which is influenced by the serum sodium level, so serum sodium levels would always be provided to you in the question. And these are the clinical features. Hypertonic dehydration leads to irritability, high pitched cry, the seizures, duffy skin because of the neurological impact. While hypotonic dehydration results in cerebral edema. So lethargy, muscle cramps, hypotension, or even coma. So serum sodium levels are the second thing. And then is the assessment of the severity, which you already are aware of. That is categorizing the dehydration into three categories, that is no, some, or severe dehydration. And you already know what are the things that you have to look for. But imagine if I ask you, or somebody asks you, that out of multiple factors, which one is the most important to determine the type of severity, then it is the skin turgor. So skin turgor is most important. And the neurological signs are the second one, which are most important for this. So once you have identified the reason, once you have identified the sodium levels, once you have identified the severity of the dehydration, now you can start with the management. Now management would be categorized into two. One is based on basic management, which is based on the severity. That means no dehydration, some dehydration, or severe dehydration. And then there is the additional management, which is based upon the cause. Like if there is a bloody stool, then antibiotics have to be added. If there is a feature of cholera, then antibiotics have to be added. If there is a feature of sepsis, antibiotics have to be added. If there is a feature of shock, then the shock has to be managed first, right? If there is a patient who is suffering from hypoglycemia, then the sugar has to be added or the dextrose has to be added. Let's first have a discussion on the basic management based upon the severity of dehydration. The first one is obviously the no dehydration. Now, in no dehydration, you just have to continue the normal feeding. That means breastfeeding in case of infants. Now, increase oral fluids, which is WHO, ORS, or home based fluids like rice water, coconut water, along with the supplementation with zinc. Now, you already know that zinc supplementation is required, which is 10 milligram per day for infants less than 6 months of age. But it would be 20 milligram per day for infants more than 6 months of age. And for what duration? Around 10 to 14 days. So, this is zinc supplementation that has to be given in case of no dehydration. In some dehydration, once you have identified that the question is based on some dehydration, then the treatment is obviously the oral rehydration therapy. That is oral rehydration solution as per WHO guidelines. And first thing that you have to initiate with is the 50 to 100 ml per kg over 4 hours of ORS given in small frequent sips along with the zinc supplementation. As you know, it will be around 20 to 20 milligram per day for the period of 10 to 14 days, and you have to reassess the patient after 4 hours. Now, if there is improvement in the symptom, then continue oral fluids and normal feeding. But if there is worsening of the symptoms, in that case you have to go for the IV fluids. Now, when to switch for the IV fluids in case of some dehydration? When is it required? So if there is persistent vomiting or worsening dehydration despite giving the ORS. And then finally, identification of severe dehydration. You have to immediately start the treatment with IV bolus of 20 milliliter per kg of RL or NS over a period of 30 to 60 minutes. Now repeat the bolus if there is a persistence of the shock, because these are the patients who are presenting with the shock. Now, once the shock is corrected, then you have to start with the 100 ml per kg IV, RL or NS over a period of 4 to 6 hours in case of infant, or 6 to 8 hours in case of children. And once the child is alert, then you have to switch the patient to the ORS. So this is the basic strategy, basic mechanism for the management of no, some, or severe dehydration. Let's start with the question. A 2-year-old child is brought to the emergency department with a history of profuse watery diarrhea for 3 days. Now they have given you a cause, and that is gastroenteritis, which is non-specific. It seems non-specific in the question. Now, point number 2 is that there is a decreased oral intake, lethargy, and irritability on examination. The child is lethargic, sunken eyes, dry mucous membrane, prolonged capillary refill time, and a very slow skin pinch. Now, these are the features which are suggestive of that the patient is suffering from severe dehydration. If you further continue reading the question, that laboratory investigations reveals the serum sodium level to be 160 milliequivalent per liter, which is high. That means it is hypernatremic dehydration. The serum potassium is normal. Osmolality is also high. The urine osmolality is 800. What is the most appropriate initial management for this child? So step by step, what we have studied till this point of time. First of all, identify the type of dehydration. The child is having a severe dehydration. Now, because the serum sodium of 160 milliequivalent per liter indicates hypernatremic dehydration, and serum osmolality is high, which is suggesting a significant free water deficit, and that also is required to be corrected. We will be talking about the formula which is needed in order to correct this free water deficit. Then you have to prioritize your fluid resuscitation, because the patient is presenting to you with the shock, because the child is in shock. The first step is to give the IV bolus of 20 milliliter per kg of isotonic fluid, that is RL or NS, over 30 to 60 minutes in order to restore the intravascular volume or intravascular circulation. Now the problem over here is that the patient is having hypernatremia, where the concentration of the sodium is around 160 milliequivalent per liter, then why are you not giving the hypotonic saline to the patient in order to manage this one? Hypotonic. Why isotonic is given? Because isotonic fluid is preferred initially because rapid correction of hypernatremia can cause dangerous shifts of the fluid, leading to cerebral edema. Normally what happens that the brain adapts to this hypernatremia by increasing the intracellular osmoles. Now, if you try to give the hypotonic fluid, then what will happen? There will be a shift of the fluid into the brain cells, and this leads to a dangerous cerebral edema and the seizures, and even the patient might end up in coma. So that is why immediate resuscitation with hypotonic saline, despite the fact that the patient is having hypernatremia, is avoided. So once you have corrected the shock, then you can start with the gradual correction of the hypernatremia. So this gradual correction of the hypernatremia is done once after the fluid resuscitation is over. The fluid replacement should be done gradually using hypotonic saline at the rate that decreases the sodium by no more than 10 to 12 milli equivalent per liter per day. So this is the rate at which sodium has to be decreased. It is not like that immediately you have to reduce the sodium. If it is 160, then you will bring it into 1 day to 135. The rate has to be 10 to 12 milliequivalent per liter per day, not beyond this. Now, another point that you might be thinking is that, once the child is adequately resuscitated, then why are we not shifting the patient to ORS? Because the child is lethargic and cannot drink properly. Once the shock management is over, then the gradual correction of hypernatremia also has to be done by fluids. Now, as we have already talked about, that free water deficit is an important component, and this deficit has to be restored. So, what is the importance of free water deficit in the dehydration management? First of all, try to understand what is free water deficit. It represents the amount of water loss now that is needed to be restored the normal in order to bring the serum sodium levels normal in case of hypernatremic dehydration. The free water deficit, it determines the volume of hypotonic fluid which is required to correct the hypernatremia safely. In simple words, this is free water deficit. Now correction should be done gradually, as I told you, in order to prevent the cerebral edema. Now, how this thing is calculated? Now, what is the formula for free water deficit? The formula is that the free water deficit in liters is the total body water that has to be calculated. How we are going to calculate? Because all of you know around 60% of the weight is water. So 0.6 into the weight for infants, while zero point 0.5 into the weight for older children. Now, this total body water, and then this total body water is multiplied by what we obtain after subtracting the current sodium levels which are provided in the question by 145 divided by 145, because 145 is the target normal serum sodium level. So let us see if the target is achieved, like if 145 milliequivalent liter is the target and it is achieved, then everything will become zero. That means the patient is not having any free water deficit and you do not require any of the hypotonic saline. Now, this is just an example. If a child is 5 years old and is having a 15 kg weight, the sodium levels in the question, like it is given 160 milliequivalent per liter, the total body water is calculated to be 7.5, and free water deficit is now 7.5 multiplied by the difference in between the serum sodium levels by 145 divided by 145, it comes out to be 0.78 liter. That means the total amount of the fluid which is required to be given is 780 milliliter of free water deficit is there. And this means that 780 milliliter of free water is needed to correct the sodium levels. So this is the amount of the fluid which is required. So after administering the hypotonic fluid slowly over 48 hours to prevent rapid fluid shifts. Once we have studied everything related to this, now let's talk about the question now, that what is the most appropriate initial management for this child. Now, if we look at the option number one, a rapid IV infusion of isotonic saline over 1 hour, as we have just talked, that rapid administration of hypotonic fluid can cause cerebral edema. So this is incorrect. It has to be slowly done. Isotonic fluids are to be given because the patient is in shock. Then IV bolus of 20 milliliter per kg RL, followed by slow correction with 0.45% NaCl. And this seems to be the correct answer based on the explanations that we have already talked about. The third one is oral rehydration with WHO ORS, not immediately, because the first thing that you have to achieve is the restoration of the intravascular volume that is achieved by the fluid resuscitation, not by oral feeds. And the patient is having severe dehydration, so the patient won't be able to take the oral feed. And finally, the fourth one, that is IV infusion of 5% dextrose in water to dilute the serum sodium levels. Against the phenomena remains the same, that because D5 alone is also hypotonic and can cause dangerous fluid shift, leading to the same mechanism, that is cerebral edema. So answer for this question is IV bolus of 20 milliliter per kg RL, followed by slow concentration with hypotonic saline. We hope that in future you won't get confused whenever you see the sodium levels which are high in a patient who is presenting with severe dehydration. Then you will not jump to the hypotonic saline as the answer. So this is the step by step approach we were talking about. Let's talk about another very, very commonly used fluid in the pediatric practice, that is isolite P. Remember, isolite P is an intravenous maintenance fluid which is specifically designed for pediatric patient, containing a balanced composition of electrolyte and glucose. Now, it is used in condition where oral hydration is either insufficient or is contraindicated. So mainly what I'm trying to say is that it is mainly used as a maintenance IV fluid in case of children. When the child cannot take the oral fluid, used for daily fluid and electrolyte replacement in order to maintain the hydration. So if I say that if the patient is having a mild to moderate dehydration, just for the maintenance, it can be used. Post-operative fluid management, like after abdominal surgery, after tonsillectomy, you have to give the fluid. So which fluid is preferred in case of a child? It is isolite P. It is again maintenance therapy. Similarly, mild to moderate hypoglycemia prevention, it can be used because it contains 5% dextrose. So it helps preventing hypoglycemia in case the child is fasting or the child is sick. The importance is that when not to use the isolite P, as we have just talked about, it is not for the initial resuscitation in shock or severe dehydration. Rather, use RL or NS, isotonic NS, is a preferred fluid in those cases. Not for severe hyponatremia, as I told you, that it is also not for severe electrolyte imbalances like hyponatremia or hypernatremia, and it is also not for rapid fluid boluses, which are used in case of emergencies. Right? So this isolite P is mainly reserved for the maintenance IV fluid in case of children. Now, the most important part of the topic is the identification of the disease and then categorize it accordingly. And now, the antibiotics which are indicated in the dehydration. You already know that whenever there is a suspected or confirmed bacterial gastroenteritis, having the signs of like bloody stools, severe abdominal pain, prolonged diarrhea, or the signs of the sepsis, then the bacterial gastroenteritis is suspected. The common ones which are kept in your question is Shigella, which is responsible for dysentery, salmonella, the typhoid fever, the Campylobacter jejuni, and these are the antibiotics as the first line to be used for these purposes. Now, what is important, as we have already talked about, that in case the patient is having a bloody diarrhea, but there is no fever, then you have to suspect that the patient could be suffering from enterohemorrhagic E. coli, and no antibiotics are given, because in that case there is always a risk of the development of hemolytic uremic syndrome. So this is one exception that we have discussed. A severe cholera is kept very commonly in your question because it is having a specific sign of profuse watery rice water diarrhea, rapid dehydration, hypotension, and the indications for antibiotics are against the same. That is severe dehydration, hospitalized cases, outbreak setting, and the first line management is by azithromycin in case of children, doxycycline in case of adults. Sepsis or systemic bacterial infection. If dehydration is associated with shock, altered mental status, or sepsis, then IV broad spectrum antibiotics are given, like ceftriaxone and vancomycin. It should be started while awaiting the cultures. And then finally is the giardiasis, the protozoal infection. If the diarrhea is chronic, foul smelling, greasy stools are associated with malnutrition, then consider giardia lamblia, and metronidazole is the treatment in those cases. So these are the common conditions which are kept in your question where antibiotics are used. Now, when not to use the antibiotics, the commonest cause of the diarrhea in case of children are the viral gastroenteritis. like rotavirus, norovirus, adenovirus, astrovirus. So in those cases, antibiotics are not at all required. So let's talk about another question with another scenario, and let's see whether you'll be able to identify the question or not. Now, 9 months old child brought to the emergency department with a history of profuse diarrhea and vomiting for 3 days. The parent report that the child has been lethargic, stopped feeding, and is passing very little urine. The general condition and the physical examination is reflective of that the patient is suffering from severe dehydration. So one thing that you have identified is that the patient is suffering from severe dehydration. Then no specific cause is given, so probably there is not going to be a question based on identification of the antibiotics in this particular one. And third thing is you have to look for the serum sodium levels. Now you see the serum sodium levels in the question are low, and the serum osmolality is 260, which is also low. What is the most appropriate initial management for this particular child? Now, here we are talking about a question related to hyponatremic dehydration. And the low serum osmolality further confirms the hypoosmolar state of the patient. Now, first thing that you have to achieve in that patient is obviously the immediate resuscitation, that is shock management. The first priority is restore the intravascular volume. How is it achieved? The same, that is 20 milliliter per kg IV fluid of isotonic ringal lactate or NaCl over the period of 30 to 60 minutes. Why? Because rapid volume extension, it restores perfusion to the vital organs. It prevents further electrolyte disturbances. Isotonic fluid do not worsen the hyponatremia, or it does not cause any cerebral edema. So once the shock is corrected, now the sodium should be corrected gradually. Why gradually? We'll be talking about it now. Now, the correction of hyponatremia that the patient is presenting with. Now, after stabilizing the circulation, switch to isotonic saline for maintenance fluid. Why not hypertonic, which is 3% NaCl? Why not hypertonic saline? Because the hypertonic saline is specifically reserved for symptomatic hypotonic dehydration. Here, in the patient is presenting with the lethargy, and there are no other specific neurological symptoms mentioned in the question. So that is why it can be dealt with the isotonic fluid as a maintenance fluid. Now, what is the goal? The goal is to correct the serum sodium levels. Again, that is true, but slowly. That is 8 to 10 milliequivalent per liter per day. And the frequent monitoring of the sodium levels every 4 to 6 hours is essential, as we have already talked about. So let's see the question option wise now. That once you have identified that the question is that of the severe dehydration where there is hyponatremia and the patient is in shock, obviously. So how will you manage the patient? Option A is IV bolus of 3% NaCl hypertonic saline at 5 milliliter per kg over the period of 10 minutes. Now, this question or this option appears tempting. The patient is presenting with hyponatremia. But as I told you, that hypertonic saline is only used for severe symptomatic hyponatremic patient where there is a feature of seizures, coma, respiratory distress mentioned in the question. The child is having a lethargy but no seizures. So gradual correction with isotonic fluid is safer. Coming on to the option B, that is IV bolus of 20 milliliter per kg RL over 30 to 60 minutes followed by slow correction with isotonic saline. This option is correct. Obviously, we have already talked about. Then the third option is IV bolus of 5% dextrose in water to correct hyponatremia, because 5% dextrose is hypotonic and it might worsen the hyponatremia. So it increases the risk of cerebral edema, worsening the neurological symptoms. So this option is also ruled out. And finally, the oral rehydration with WHO ORS containing serum sodium of 75 milli equivalent per liter. The child has severe dehydration. The child is in shock, requiring IV fluid. So this option is all obviously ruled out. One thing that all of you might be wondering is that what is the role of dextrose then in the form of the IV fluids? The dextrose containing fluid in dehydrated patients depend on the underlying cause, the severity, and the metabolic status of the child. Now, what are the main indications? The first indication obviously is hypoglycemia, where the blood glucose is less than 45 milligram per deciliter in case of neonates or less than 60 milligram per deciliter in case of infant or children. Second is hypernatremic dehydration. Here we have already talked about remember, it is never used for the rapid correction. It is used during the gradual correction of the serum sodium level. Then obviously the diabetic ketoacidosis, then rehydration in malnourished or pediatric ICU patients, or in the patients who are presenting with shock with hypoglycemia or lactic acidosis. So I hope you have understood the lecture. I hope you would be able to identify what are the key important features provided to you in the question related to dehydration. I just hope that the session was of some help to you. All the best for your future examination. In case you do not want to miss any update, please join our Telegram group. The link is provided to you in the description. Thank you.